I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel I. Welcome to another episode of Fridays with Faisel. We're here because everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is accelerating adoption of new models of care. What do I mean by that? The current healthcare system is fee-for-service. More than 95% of the reimbursement in healthcare in America today is fee-for-service. It's a transactional system. It's a system that is based on billing, generating revenue by billing. And you usually bill when you're reacting to a problem or a condition. So you generate revenue by billing for things like tests and procedures and referrals. There are new models of care where the incentive is to focus on prevention and early intervention. So I'm excited to get started with our topic today. Robert, how are you doing?
Hey, Faisel, how's it going?
Great. I hope you've had a great week.
I have. It's been very busy. So
I know you've been busy.
That's why I wasn't on the promo video this week.
That's right. We missed you on that, by the way.
Yes, I miss being there as well. But we're here, and this is a very exciting topic. It's one of my favorite things to talk about. It's what my book is about. So are you ready to jump into it?
Let's do it.
Okay, so let's bring up my first diagram. Let's set the stage here, Faisel. We have a fantastic guest today to talk about this. So I brought this up last week, but I have two graphics here. This one, I think, really illustrates where a lot of the new models of care are focused. So a lot of these are starting to look at patients and their health experience more holistically from not just the healthcare service perspective, not just the medical model, but looking at individual behavior change, looking at social and economic factors that impact health outcomes. And so this is sort of driving a lot of sort of the development of new models, like what you guys do with ChenMed, like what's being done in some virtual care models, like what we do at Avenue. And so, there's a lot of emphasis on saying, okay, we know that just, patients coming in under fee-for-service, having a 15-minute visit, getting a care plan, telling them to go home and come back 3 months later is not very effective at managing chronic illness. And it's certainly not very effective at managing higher risk patients that need a little bit more intensive care, a little bit more service. And so this sort of approach to how we view health through those behaviors and those social economic factors is really starting to make its way into the mainstream, and it's informing a lot of the thought of new models of care. And so can we bring up the next graphic? So in addition to looking at the factors that affect health and health outcomes for individuals, there's also the sort of system perspective here. And where a lot of these new models are focusing is in the areas of transition. And so patients are, usually pretty well cared for if they're in a facility, they're in a clinic, but the amount of time they spend in that facility or in that clinic is a lot less than how much they spend in the home or, when they transition out of those facilities. And so sort of the classic example of where a lot of innovation happens is in these transitions of care. So a patient gets admitted to the facility, they move to a post-acute facility, or they move into the home. What's being done there to make sure that they don't come back to a hospital? And then again, in the primary care space, that's where that prevention focus is really important. So preventing people from ending up in the hospital or going to the emergency department in the first place. And so all of these areas of transition are of lots of focus for these new models of care. And so today I want to discuss some of the work that ChenMed's doing in these areas, some of the work that we've seen in these areas, and then how do we actually get other organizations to learn from these lessons and to adopt these new models. And so that's the topic for today. And Faisal, why don't we introduce our guest?
Definitely. Well, first we gotta get Dr. Dan. Dr. Dan. Dr. Dan, it's
Hey,
good to see you again.
hey, Faisal and Robert. Great to see you as well.
You too, Dr.
Dr.
Dan.
Dan's going to be manning the chat room and bringing in some of the comments. We really encourage people to comment in or ask any questions so that we can then discuss it. We can quickly pivot in order to do that. We have an excellent guest joining us today. He's our National Director of Acute and Post-Acute Care, Dr. Salomon.
Hey, Faisal.
How are you doing?
Doing pretty well, man. Thank you for having me here today. Looking forward to this conversation that's really, really close to my heart. Thank you for having me.
You know, most people don't know that at least pre-COVID, half of all medical care was delivered in the emergency room setting in the country. And I believe it is because the established model incentivizes reactive care. You know, when patients are going to the emergency room and getting treated for pneumonia and getting their insurances, you know, the hospital is billing $10,000 for pneumonia, and the insurance company is getting, you know, they're paying whatever they end up paying, $7,000. That same pneumonia could be treated in the outpatient setting the same exact way for less than $7. It's literally 1,000 times more expensive. So the hospital systems have zero incentive to switch from this reactive model towards a model focused on prevention and early intervention, especially if you need specialty care. You know, and the coordination of that needs to be physician-led, primary care physician-led. So I'm excited to have you here, Say, especially with your insights, with all the work that you do, with having to get involved with maybe in the fee-for-service world, a particular admission would be okay for 5 days, and then Dr. Salomon gets involved and suddenly turns it into a 1 or 2 day admission. So it'd be great to hear. And then everything else that's involved as well.
Let's get it. Let's get started.
So Dr. Salomon, why don't you introduce us to your, sort of your role and some of the things you do to, keep patients healthier, keep them out of the hospital, and to really improve sort of those transitions of care from the acute facilities.
So it's a team effort, first of all. So team effort supported by great technology to allow us to react in more of a, real-time way. So our model is based on a proactive approach to healthcare, right? But when somebody does go to the hospital, we do get into a reactive mode. So looking more so on a reason why. So an admission for us into an acute care setting is an opportunity to learn why. What did we do to not support the care of this patient in the outpatient setting, and learn from it? So it starts there. It also starts with making sure that the primary care doctor is kept at the center of the care of this patient in the hospital setting. So making sure that those lines of communication are open from the moment that person walks into the emergency room. It's incredible how we have created relationships within the fee-for-service model to allow us to provide value-based care within the hospital setting. It's humbling to me, but it all starts on finding those physicians out there who have identified the fee-for-service model as not being the most effective care for their patients, and partnering with them and influencing them to be able to provide the care the way our patients deserve to get care.
Excellent.
It's physician-led. When you mention that, it is a physician-led way of practicing medicine. And I think now, you mentioned with value-based care, I think it's important over here to make a distinction between different types of value-based care.
Mm-hmm.
So the first general type of value-based care is where there's no downside risk at all. It is just called shared savings. The next type of general value-based care is where there's now some downside risk. And then the third general type of value-based care is the full or global risk model. And the full or global risk, and the difference between full and global risk is just with global risk, which is what ChenMed's a global risk organization. We only take on global risk contracts where we're full risk, including medications, makes up less than 1% of all of healthcare in the country today. So there is definitely a distinction with the different types of value-based care. In fact, what I'm learning is that I've read about half of all payments in the country are value-based. But these are these hybrid models that are really rooted in fee-for-service. So Robert, you mentioned about 15-minute visits with the doctor. The average doctor is spending 15 minutes documenting each patient encounter.
Right.
So there's already, the fee-for-service world is a place where there's little to no value. The doctors are getting burnt out from busy work. And so now with these hybrid models, not only are they having to spend all this time documenting each patient encounter when the patient is in front of them, but now they're having to do all these clicks in the So these are systems that are still rooted in fee-for-service. So with the global risk model, where we don't concern ourselves with billing, the doctors can focus all their attention on the medical complexity of the patient in front of them, rather than the medical complexity of the documentation. Does that make sense?
Yeah, it does. And, it's all about how much time is actually allocated to spending on patients rather than, just documentation for documentation's sake. But you at ChenMed have the incentive then to ensure that wherever your patient is in their transition or their continuum of care, from the home to in the hospital to outside the hospital, you are at risk for their care. And so your responsibility then, it doesn't matter if there's another doctor in the hospital caring for them, it doesn't matter if there's a skilled nursing facility caring for them, you are at the end of the day really responsible for them. And so being in this full risk model, you all have to operate a little bit differently than a lot of clinics who under fee-for-service really just do what they do in their own scope. And if they go to the hospital, there's another doctor to take care of it. It's not my responsibility. So what do you guys do from a post-acute perspective, Dr. Salomon, to actually manage the patients better? So what are some really specific things that you work on to actually save costs and to improve those patient transitions?
So several things, but going back to Faisal's point, so being full risk or full capitation allows us to be innovative in this model of care. My teams don't worry about time spent on a patient, time spent on the phone, making sure that they get transitioned. We just get the job done because it's what we're here to do. So once that patient is ready to be discharged, and mean ready for the discharge from the moment they step into the hospital, we start planning for discharge planning, right? Can this patient go home? Do they have enough support? Will this patient need care in a post-acute care facility? So from the moment they step into the hospital that they're admitted, we start working on the discharge plan, reaching out to the hospitalist directly, making sure they have all the information they need to avoid repetition, to avoid any consultative services that are really not necessary because these patients are cared for by our doctors. Avoid a consult. The most avoidable one to me has always been that nephrology consult. A lot of our patients carry that diagnosis of chronic kidney disease. So if you're admitted to a hospital and you were there 5 years ago and your kidney function was normal, and you present with a renal, creatinine of 3, for example, acute kidney injury. No, this patient has been having this issue for the past 3 years, pretty well stable. Here is the proof to show that. So you can avoid that consult that will translate into 2 or 3 days of a length of stay, just working the patient up. So for us, that and people would say, well, you're not, you're influencing the care. No, patients getting the best care they need. They went in there for pneumonia, for example, that couldn't be treated in the outpatient setting. Let's treat that pneumonia and let's have them follow up with their primary care doctor. Once that patient is ready to be discharged, we assist the hospital in getting them to providers that share our mission and vision, right? Those home health agencies that will communicate with Faisal and Dr. Dan to say, hey, your patient is getting these type of services. That skilled nursing facility that allows us to follow the patient throughout. I have doctors in certain markets that follow our patients in the skilled nursing facility. And if that patient, doesn't need to be in that facility an extra day for a requirement or extended length of stay, we get that patient transitioned home as safe as possible. So it's walking through the patient throughout every level of care. But even before they go to the hospital. So our PCPs have access to community case managers who their sole job is to be out in the community. Their sole job is to walk our patients through their medications, making sure that it's safe for them at home, making sure that there's no issue around food or housing insecurity. Do a fall risk assessment, right? falls is one of the leading causes of hospitalizations. And if our PCP is worried that that patient is going to fall at some point, we're deploying a team out there to make sure that that fall risk is mitigated. I have personally done home visits, and I have persuaded patients of throwing out rugs that are fall hazards, right? And explaining to them why. I've identified crack sidewalks, worked with their cities where they live to fix it. So is taking, staying one step ahead. I like to tell my teams that we all carry a detective badge. So we want to make sure that we investigate as much as possible to avoid a hospitalization. That's always the number one goal. Avoid a hospitalization where we can, to make sure our patients are safe and healthy at home.
Right. Dr. Dan, I think you have a question.
You're muted, Dr. Dan.
Sorry, there are a couple of questions here. Gloria is asking, how do we handle general patient emergencies? And I think Dr. Salomon, I anticipate that he's got a similar answer as to how we handle getting them out of the hospital as to how we handle keeping them out of the hospital. But I'll let you all have at that, and then come back with the other question in a minute.
So thank you, Gloria, for your question. So the moment our patient steps into an emergency room, we are aware that they're there, right? So that awareness allows us to start helping that patient and that healthcare system care for that patient. If that patient is there for high fevers, it could be that we started treating that patient already in the outpatient setting. So we provide that physician with the plan of care that the PCP has established, so they avoid repetition and they can really streamline to the cause of that fever, right? That patient was being treated for a simple UTI, urinary tract infection, by their doctor, and they then present with a fever. The likelihood is that is related to that urinary tract infection. So for us, it's the moment they streamline into the emergency room, we are caring for them. And you would say, well, we're not a 24-hour operation. We are. Our patients have access to a doctor who's on call. The majority of our patients go to the emergency room during the day. So there's always somebody who's tracking that they're there and the reason that they're there, so we can streamline the transition as smooth as possible.
And I'd like to add for anyone who's wondering why we focus on reducing these unnecessary hospitalizations. Well, you have to understand that we spend as a country over $17 trillion. Out of our total GDP, we spend just over $3.5 trillion on healthcare. And over $1 trillion of what we spend on healthcare is medically unnecessary, meaning that it's wasteful. It was not needed to begin with. And the number one driver of waste in healthcare today is unnecessary hospitalizations, which is fueled by unnecessary emergency room visits, meaning that these visits are visits that could have been treated in the outpatient setting. And then a very, very distant second place would be unnecessary specialist referrals. And then an even further away third place would be overprescribing of brand name drugs when there's a generic drug equivalent available. And so by focusing on prevention and early intervention, efficient intervention, then patients will not end up going to the hospital. And if they go to the hospital, it's because they really needed to go to the hospital.
Mm-hmm.
So Faisal, if I'm your patient and I call you, because I have your phone number, and I say, I'm having severe abdominal pain, and let's say I'm a 71-year-old woman, and I'm calling you, and I say I have severe abdominal pain. What is your step? So I didn't go to the ER. I decided I'm going to call my doctor first. What steps do you take to manage that patient?
We immediately triage the situation, and we do this, and we've been trained to do this from when we were in medical school. Anyone who's gone through medical school or even an intern, first year in residency, when you're on call overnight at the hospital, you have a hospital with over 400 beds, you handle a lot of phone calls similar to abdominal pain, similar to fevers, similar to a lot of the complaints that patients will call their doctor for. So we'll triage the situation and evaluate, is this something that can be managed at home? Is this something that can be managed in the clinic? Or is this an actual emergency? We make that determination over the telephone. We provide the transportation for all our patients. Actually, one of the things that we're most famous for is how we Uber patients who are from the emergency room to the clinic. This is something that we frequently do. How do we get the notification? How do our doctors get the notification that their patient's in the emergency room? Dr. Say just mentioned. As soon as they swipe their insurance card, there's a complicated process that eventually ends up becoming a text message on my phone that my patient is at the emergency room. So we get involved right away. Actually, for us, when they already hit the emergency room, it's too late.
Right. Okay. That's. I think that fully answers the question there. Dr. Dan, I think you're back.
Yeah, I am. So Kimberly had a couple of questions here. One was, when you say full cap, is this inclusive of codes that are preventative? And I'll just go ahead and answer that and say, yes, it does. It includes everything. So when we say full cap, it includes everything. And then a follow-up question is, when you're working with providers and other ancillary services in this entire model, does the financial model line up for every entity? That's a good question. So I'll leave that to the panelists to work on.
So I'll jump in here. I'm not going to speak for ChenMed because I'm not sure how they work, but I'll tell you is that this is a big problem in value-based payment global cap world. And so the way that ChenMed, I believe, has solved this is they actually just make sure that they're following their patients throughout. When you build these sort of global cap models and you have one organization responsible for the risk of the patient, and then they don't have really those good connections with the other treating providers, it becomes hard for that organization under risk to assert their, kind of, I guess, incentive on those other organizations. And so one of the classic examples is a hospital that has, a risk contract, and then they don't really have control over their post-acute or their home health care providers. And so, when the patient leaves the hospital, they're really not able to necessarily intervene to prevent that patient from coming back. And so I'd be curious to hear how you guys have handled this at ChenMed. It sounds to me like you are just a little bit more aggressive about making sure you're following your patients around, and you are trying to get in there, and you've built some technology systems to be able to do that. So I'd love to hear, how you guys are handling this at ChenMed.
Well, technology is at the center, right? So following our patients real time makes a huge difference. So that's one. Second is, my interactions with systems is that they really want to partner with providers that are going to take the responsibility of following those patients across the continuum, right? We read an article last week about how hospitals got penalized for readmissions. So when I'm meeting with a hospital, I am actually offering them a solution to an issue that can financially impact them, right? Avoiding that patient gets readmitted. Emergency rooms really don't want the patient there seeking primary care. So I'm there to offer that solution to them. So once it's different payment structures, but for the most part, the patient is at the center of this, and systems really want to collaborate with providers, especially like us, who are there to help them solve inherent issues that they don't have the ability to do so. Big hospital systems are not primary care providers. They're not there for that. So if they find somebody like us who is willing to assist them, I think it's a win-win. So relationship building and educating folks on our model, which is around taking care of people, I think it's key there.
Yeah, you have to identify what the priority ought to be for everyone. So across the board, our healthcare system number one priority ought to be to improve health. It ought to be number one, should be whatever we're doing here is the health and the quality of life of the patient being improved. Is the patient feeling more stressed out? Like by the time, I'll give you an example of what I've had to deal with this week with my own mother. So my mom called me, today's Friday, Fridays with Faisel. So my mom called me on Wednesday morning saying, you know what, last night I got a little startled because the mailbox looked blurry to me. And I told her, and she said, I'm supposed to be getting glasses for the last year, and I just haven't gotten around to doing it. And I said to her, but Mom, wait. You said you felt a little bit startled? This is a new thing? So in my mind, all I'm hearing is sudden loss of vision. And I'm worried that she has this painless sudden loss of vision. Oh my God, is this like an acute closed angle glaucoma? Is this an emergency situation? I had to evaluate the situation with my mom, who was she was not aware of what was going on, or even my concern. She thought I was being overreactive, and I was able to do a quick evaluation over the telephone and make some phone calls, and then get her to have an ophthalmology evaluation the next morning, yesterday morning. So she had a thorough evaluation, and it ended up turning out that she has glaucoma, and she needs to have 2 stents placed, possibly, as well as 2 cataracts, one aggressively forming cataract in her left eye. And she was terrified. The whole process, when she found out that I was worried that this may be an emergency situation, and then saying that, oh, you got to go see a specialist, I had to take care of all of that for her. So she just had to show up. Because when you're in that scared state of mind, that, my God, I don't know what's going on, you need to be carried through the process. And the incentive needs to be to make sure she doesn't have to go to the hospital unless she absolutely needs to go to the hospital. And so now all the care has been coordinated. I made sure I even got the primary involved to make whatever fasting lab work done this morning. She's feeling much better knowing that everyone is working together to take care of her and to prevent an emergency from happening in the first place. You see, the current system is not incentivized to provide that type of level of aggressive prevention, or aggressive, as I would say, aggressively efficient way of managing the patient. Otherwise, she would end up being an emergency, like half of all medical care in the country, at least pre-COVID.
Yeah.
You made a
Go ahead.
you made a huge difference there. So you spent time, right? Where that's translated into value. Somewhere else would have been, volume sent to the emergency room, right? But if we should get reimbursed for spending time like that in prevention mode, not
Right.
volume. So to me, you put something out there that sounds so logical, right? And I don't know why we haven't been able to figure that out.
Because the incentive wasn't there, Say. The
Yeah,
incentive wasn't there. And actually, if you wouldn't mind talking about how we pick and how we design our referral networks, so to try to make care, because care right now, if you think about a PPO, your typical PPO, patients can go see specialists without involving their primary care doctor. And so you'll have specialists who are treating patients who don't even talk with each other, and there's no primary care doctor involved. So if you can talk about what a little bit about our referral network, how we try to make things a little bit more efficient, much more efficient, I should say, and then as well as how we work with SNFs.
So our referral network is, again, keeping the primary care doctor at the center. So identifying those physicians in the community that share our mission and vision, and bringing them up forward to the table to have the primary care doctor educate them on the way we provide care. For us is really novel. Not every primary care doctor provides care the same as us, right? So we encounter doctors in our specialty list that need to be educated, reassured that we handle the entire care of the patient. And when we reach out to a specialist is to answer a question that we may not have the answers for. So typical patient that needs a screening colonoscopy, right? Typical is you refer the patient to the GI physician and he does his assessment. 3 weeks or 4 weeks later, they schedule the colonoscopy. We do that first visit at the center. So once we're reaching out to that gastroenterologist, they have already all the information they need to perform the procedure and then send that back to us. So that is the type of doctor that we partner with. And it's very, we have our network team that does a fantastic job helping us identify those providers. We also follow their metrics and outcomes. So you can be on our list for some time. And then if for some reason your metrics are not up to our par, then we find another provider. So it's a very fluid list, but also making sure that once they see our patient, we get those notes back as soon as possible. So we can educate our patients on the outcome of that specialist visit. When it comes to...
Well, I just want to say, sometimes we don't even wait for the note to come back.
Nope.
When you have that relationship, if you think about how relationships used to be like with primary care doctors and specialists in the community, going back 30, 40, 50 years, that's the way ChenMed is basically operating. This is one of those things where old becomes new again. ChenMed has a model that is now 35 years old. And so when I send any of my patients to any specialist, they're calling and texting me, real time that, hey, this is what's going on with your patient. And then I let the patient know, hey, I just got off the phone with the specialist. I mean, when you're thinking about what the attention of a board certified primary care doctor, what should they be focusing their attention to? They should be focusing their attention to the most medically complex. We're not just talking about 1 or 2 chronic medical conditions here. Our average patient is 72, 74 years old, anywhere between 5 to 7 chronic medical conditions. So a doctor's time with making evaluations with something as simple as a medication refill or as simple as a referral renewal when you're dealing with such a medically complex panel, and oh, by the way, they're all on fixed incomes, earning like $600 to $900 a month in Social Security. The focus ought to be on making the care as understandable and simple for the patients. It reminds me about having the culture of patients coming second. You see, when you have a culture where patients actually come second, people kind of really shocked. What about all the stuff at Patient-Centered Medical Home? What about Patient-Centered Medical Home? No. What good are we to the patients if we don't take care of our doctors first? That's why you have the burnout situation you have in the country today. Doctors in America aren't getting burnt out from medical complexity. Doctors in America are getting burnt out from doing all the non-doctor work that somebody else should be doing other than a board-certified doctor.
Mm-hmm. Go ahead, Dr. Dan.
Oh, so we've got a question from Henry now, and we appreciate Henry joining us again. We see him quite a bit. So his question is, how do you evaluate the quality of skilled nursing facilities? How do you collaborate with SNFs between your PCPs and, let's say, their RN at the SNF? And that's probably a great question for Say.
Henry, thank you for the question. So I'm going to tell you what most people do. What most practices do is they follow the insurance provider's list of approved SNFs, and that's it, right? What we do is, and what I did, somebody from Broward County is on, so they know I did this, is that I took the list of facilities that we more frequently our patients get transferred to. And I looked at the CMS website and the Florida State website on ratings, right? That to me wasn't enough. So I picked the top 8, and I went to each of those individual facilities with my business card and presented myself. And I actually sat in their rehab center. I wanted to see what was the quality of the rehab that the patients were getting. I wanted to see what was the quality of nursing that they were getting. Actually, and even the food. So, I did that some of a field trip to each facility. It took me a couple of months and allowed us to build what we call a preferred provider list for our skilled nursing facilities. To top that, we are in some areas, for example, here in South Florida, we have a physician and a nurse practitioner that actively follow our patients throughout the skilled nursing facility with the goal of, reducing, length of stay, right? There's some devious practices out there. Also making sure that they don't get readmitted to the hospital for things that could be treated in the post-acute care arena as well. So it's partnering directly with them, again, educating people about our model of care, which is uniquely centered on making sure that our patients have more healthy days and a better quality of life during this time in their life.
You're right. And so this is something I hear in our conversations a lot, particularly with the ChenMed physicians. It comes down to relationships with your patient, relationships with the other providers that take care of your patients. So taking the time to actually build those relationships, make them meaningful, and to make sure everybody's sharing that information nicely. And then that's part of your entire clinical model is making sure that everybody's on the same page and that somebody is looking after that patient, as well as in most settings spending a lot of time with that patient. The other thing that is obviously enabling that to happen, and this goes back to the topic today, which is how do you diffuse the adoption of these best practices? You at ChenMed, you have demonstrated significant, excellent outcomes for patients. We want more patients to be included in these types of models. And really it comes down to those payment incentives, because organizations that offer healthcare are operating in a financial structure the money does often create the incentives and the capabilities that are possible. And so this full risk model, when we really get down to it, is what can make a lot of these models more accessible to other organizations. So I think some things that you guys do at ChenMed are exceptionally just like translatable right now, even to fee-for-service providers. But at the end of the day, a lot of what you are able to do and accomplish comes directly from the fact that you're under full risk. And, you know, as much as I like to say, oh, we can do it like this, we can do it in fee-for-service, I think there's some things at the end of the day, like that's what allows you to do what you're doing. And I think that that's why there's so much attention from the policy side and from the payer side on these full risk models and helping to build them with organizations that can kind of replicate what you've accomplished. And so, you know, what advice do you have for the physicians that are still operating in a fee-for-service or the administrators that are operating a fee-for-service primary care organization to, you know, take some of what you're doing right now until they can adopt full risk?
I part of the issue that we have is when you have primary care doctors with patient panels of 2,000 to 3,000 patients, they're spending 20 minutes of FaceTime per patient per year. They're spending 15 minutes documenting each patient encounter, and they don't have the skills or the time, quite frankly, to motivate patients to make better life choices. And so when you have a culture of motivational interviewing, you know, where we have to do that not only with the patients, but with the hospitalists, with the different specialists, with everyone that we have relationships with, and integrating the care. Because right now, the care in the fee-for-service is very fragmented. Actually, the more inefficient a care, now I'm not saying malpractice level, but I'm saying the more inefficient a care is, the more money is generated, right? You end up needing more people to be involved, more hands involved. What happens when you integrate behavioral health into primary care? What happens when you have the social workers or the psychologists integrated into primary care, helping the primary care doctors have those conversations with let's say if let's pick on COPD and smoking, right? So the patient comes, and it's also the mindset of the chief complaint versus the primary concern. We hear it all the time as doctors. So you have a patient who's having a COPD exacerbation every 2 or 3 months because they're still smoking, and they show up with the doctor with a chief complaint of low back pain. And the doctor spends most of the visit addressing the low back pain, documents for the low back pain. The chief complaint was low back pain, assessment and plan, low back pain. But meanwhile, they didn't talk about the COPD exacerbation because the patient is in between COPD exacerbations and like, okay, next time we're going to talk about the COPD exacerbation. That's not how it works in the full risk model. In the full risk model, the minute clinic visit is the patient's chief complaint. And that's why all these standalone emergency rooms are popping up all over the place, because it's an entire model that's based on the chief complaint rather than the primary care doctor's primary concern. So we handle it that, okay, this is your chief complaint. I will address your chief complaint. In my mind, that's my minute clinic visit. But now let me tell you my primary concern. You're in between COPD exacerbations, you're still smoking. These are steps that you can take to prevent the next exacerbation. And then you find what is it for that particular patient in front of you that will motivate them to take whatever steps in order to have the desired outcome that I want for them as a doctor, and really what they want for themselves to improve their quality of life.
Mm-hmm.
So, Faisal, we have a question from Sergey. Following up on your burnout question is, why are doctors still involved in patient onboarding? How do we eliminate that unnecessary routine so doctors can do their creative work, the one they've been trained for in med school and during their career? And, I think that's a good question. I did some training in lean process improvement, and in lean, there's an idea that you're looking to get the waste out, but there is value added activity, there's necessary non-value added activity, and then there's pure waste. And so maybe you want to talk, I think there's always going to be some necessary non-value added activity, but how do you get the pure waste out of this? And see what you all think about that.
I think I'm a firm believer that having the right people in the right position that are mission driven is the key to allowing a physician to be a physician. So if you have, we call them care promoters. You have a care promoter here that is operating at the highest level of her ability to be able to make sure that that patient has all the information they need or reminds them about their next appointment, then that doctor could be a doctor. If you have a patient that is calling in for a medication refill or for a question about their medicines, and you have a capable pharmacy tech that can educate them, then the provider is focused on seeing patients. So I think it's making sure that the right people have the right seats on the bus, but also making sure that you have the opportunity to coach them and elevate them if they're not operating at the highest level of their license. So to me, that's key. I think that's where here at ChenMed we make the difference, is making sure that our PCPs have the support staff in place to allow them to be doctors. I tell people, I'm not a PCP, right? And I have a very long fancy title, but I am here to support the PCPs. Anybody who's not a PCP, a cardiologist, endocrinologist, somebody like me is here to support the PCPs, to make sure that they can focus on seeing patients, making sure that they can focus keeping our patients healthy and happy and at home.
Yeah, doctors shouldn't be concerned about things like prior authorizations and getting these things approved and all that sort of thing. The doctors should be focused on doctoring and let everyone else do whatever it is that they need to do. Now, I can tell you with myself, when you're growing a full risk panel, when you're growing like this global risk panel, I remember I wanted to have a lot of control over how I grew my panel with like-minded people who wanted to have that doctor-patient relationship with me. So I was that person, especially when I joined ChenMed. I joined ChenMed as a primary care doctor. And that was 5 jobs ago over the last 3 years. Thank God it was with the same company. Otherwise we'd have a problem. But when I joined ChenMed, I remember I wanted to grow my panel with like-minded patients who wanted to have that doctor-patient relationship. And I found that when patients would tell me, hey, I've never had a doctor treat me like family before, I would use that as an opportunity to say, hey, do you know anybody else who would like to have a relationship like this? Because it turns out that actually people, like-minded people, I mean, that's human nature, right? We all kind of get along with similar like-minded people. Many of my medically complex patients also had friends who were medically complex, who were desperate to have that type of relationship with their doctor. So I particularly enjoyed growing my panel on my terms, working closely with the sales team and with different marketing people to help me to grow my panel on my terms. I actually enjoyed it. Because remember, right, in our world, our doctors average between 350, 400 patient panel. We cap off our doctors at 450 patients. So when you're only dealing with a small number of really medically complex patients who are on fixed incomes and they're seniors, they're on average age 72 to 74, you can have a lot more say with how you grow your patient panel. So that because it becomes your panel. These are my patients. It's like taking care of your family.
And Faisal, I think that most patients, at the end of the day, if you were to ask them, would probably say that they want to have a nice relationship with their doctor after you get down to it. So I think that's obviously a universal concept that can be taken by other people that are able to spend this much time with their physicians, and that's I think why your model is so effective. And so let's take a moment here and let's all kind of go through sort of their final takeaways from this conversation. I think it's been really great. So, Dr. Salomon, why don't you go first, and then Faisal, what's your final takeaway? Or I'll go next, and why don't you go last, Faisal?
Sure.
So kind of one final takeaway, for people who are watching this, what should they have learned? What do you think is really important to leave people with?
It was great being here. I really appreciate the time. Models like ours, who are full risk, full capitation, allows us to be innovative in the way we provide care to patients. Our teams are an innovative approach to care that not most patients have access to. So walking a patient through the transition of care from emergency room to hospital ward to back to the community is something that should be standard and shouldn't be a privilege of being a ChenMed patient. Most patients should have access to that in a way that is personable, surrounded around their care needs, but most importantly, always guided by the care of their primary care doctor. So for us, that to me is what this model has allowed us to do. That's our craft, and in regards to making sure that our patients are transitioned from the hospital to home and they stay happy and healthy and safe, which is most important right now in the time of COVID.
Excellent. So my takeaway here is, first of all, the biggest thing that allows these types of like really effective care models to diffuse across the health system is an acceptance of these full risk models. So that gives physicians their time back, that gives organizations some capital to be able to invest in new models and to new technologies. And so that is a very effective mechanism to get this into the hands of more patients and more physicians. For our fee-for-service friends that are out there, I will say that for Medicare patients in particular, CMS has rolled out chronic care management codes and PCM codes that are available to fund some of these best practices that have been illustrated by ChenMed. Still codes, still some documentation, but there is funding available if you are interested in rolling out these types of programs. And so those codes are actually severely underutilized. And for PCPs that are out there that do accept fee-for-service, there is some funding to make this happen. So do take a look at those.
Thanks, Robert. And thank you, Dr. Say. The current system with CPT codes and billing codes is burning out doctors. It's burning out doctors and it's hurting patients. So all the new models of care are moving towards value. And when we talk about moving towards value, we're not talking about these shared savings or these hybrid plans with some downside risk. What we got to move towards is what Dr. Dan likes to call full value. When you say full risk to any doctor, if you look at any of our 401ks, there's nothing risky about our 401ks. Our initial inclination is, hey, can we try the shared savings? Can we try doing some downside risk? And we end up getting hurt in the process. Once you realize that the number one driver of waste is unnecessary hospitalizations, which is fueled by unnecessary emergency room visits, it'll be clear to see that the models of care that incentivize prevention and early intervention, I would say early and efficient intervention, are the ones that are the best for patients because it improves their health. And it's also the best for the doctors and the care teams because it improves their quality of fulfilling their purpose of why they got into healthcare in the first place. And Dr. Dan, I'm sorry.
No, I think you all are hitting on it. I think for the people in fee-for-service, it is hard to think about making that transition. And I think the tendency is to go to the hybrid model, but then when things get stressful, to jump back to fee-for-service. And I'll tell you, you really have to have a plan. You're going to have your foot in two boats. I understand you can't go all the way to value right away, but you need to keep making the transition to value because that other boat is going to go away. It's taking on water and it's not the safe place. Even though it's larger, it's not the safe place you think it is. So don't be the people on the Titanic that are waiting to get on the later lifeboats. It's time to make the move to the lifeboats now.
Thank you, Dr. Dan. And for all the commentary today and the interaction, thank you to our guests. Thank you, Dr. Say, Salomon. Robert, as always, thank you so much for just another great conversation. I really enjoy us taking time over our lunch break. We're in the East Coast. So we take time over our lunch on Fridays to just talk shop about how to restore the doctor-patient relationship. To anyone in the audience as well, thank you for interacting. We hope you enjoy how we bring in some of your comments and questions and try to answer them in a down-to-earth and straightforward manner. For more information about today's topic and to explore opportunities with ChenMed, please visit ChenMed.com. We believe access to primary care is a right, not a privilege.